talking today to Jessie Cunnett, who is the founder and director of Patient and Public Involvement Solutions, a company that enables people and organisations to work together to make better decisions. That's in the British National Health Service. Jessie, give us a flavour for what you do.
I guess the best way to describe what I do is that it's about trying to make sure that the decisions that get made by organisations who are trying to serve the interests of the public, in this case health and social services, that happens in a way whereby the people are at the very heart of those decisions, and that those decisions get made in the best interests of the people, not in the interests of the management, not necessarily in the interests of a clinical person, not in the interests of the budget line, but that it gets made in the interests of the public. All of those other factors need to be taken into account, but it's essentially about trying to design systems and processes that bring people to the heart of the decision making in different ways.
And we're going to ask two sets of questions today. The first are general questions about the issues that inform that broader background that you've talked about, and then we're going to talk in some detail about what patient involvement can mean for driving those choices. So first off, one of the suspicions one always has about the National Health Service is that it's organised for the convenience of the producers, in other words, the doctors, the nurses, and so on and so forth. And I think the best way I can sharpen that as a way of describing it is there was a study not so long ago showing that more people died at the weekends where there were less senior doctors on duty. How do you, in a sense, deal with that issue? How do you deal with the fact that public services tend to organise themselves in their own interest?
I think the NHS and the health service is a particular interest because it tends to be run by people who have a very high degree of knowledge about a subject that many people don't know, for medical knowledge. So it's a kind of knowledge-based power, which means that as a person or a recipient or a patient who's in need of health care or social service care, we need to know the answer to questions, or we need somebody to help us who has knowledge and understanding that we don't have. Otherwise we would help ourselves. But actually we haven't had the benefit of the medical education, we're not inclined that way, it's not our interest, and we need to seek the support and help of a profession who has within it a sense of knowledge, rely on that. And therefore that, I think, allows the health service and the health service in general to be able to operate in a way which is often unquestioned, because there is an assumed sense that this is a doctor who's had 7, 8, 9 years of intensive training. He knows the answer to the questions that I need in order to make me feel better again. So that's, I think, one thing. So there's a real sense of the power of knowledge, that real kind of traditional power. I think the other aspect of that, particularly in the health service, is that people use those services when they're unwell, without stating the blindingly obvious. When one is unwell, you are usually feeling vulnerable. You're not necessarily in the mood to help yourself. You need somebody to help sort you out as quickly as possible and get you back up on your feet. So you set up, before you've even begun, a fairly paternalistic relationship where there's a needy person and there's a person who can provide what is needed in order to resolve the problem and move forward. So even at that level of, I'm not well, I need you to help me get better, you're already in a situation which helps the person in control or with the more power to be able to harness even more, harness that and to grow it and to reinforce it and to kind of create that power. Even to use a kind of a personal example, as somebody who's been working in this field for 15 years, about 7 or 8 years ago, I had an operation that went wrong, and the doctor came to see me and he said, I'm really terribly sorry, something's gone wrong, we need to do a bypass of your kidney temporarily. Now at that point in time, I would have, if he'd said to me I had to wear a kidney on my head for the rest of my life, I would have said, do it. I don't care. Now the fact that actually he had been incompetent and that he'd put a hole in one of my tubes accidentally in doing what he'd done, and actually what I should have been saying was, what do you mean you've done that to me? Automatically you are in a situation whereby that power difference is in place.
It's very strong.
I think there are a number of other things that sit around that, and I think the reason why I'm talking about the power so much is because I think that's where this lies in terms of why do we allow, or how do we move away from the producers always being the ones who are leading forward, because that power difference for me is fundamental, and it's there in lots of different ways. So when one is vulnerable and you go into a hospital, for example, and you need help, you arrive in a big large building, you are nervous, everybody else there is in uniform and part of the club, so all of the staff are part of the club and you're not in the club. You arrive, the building is usually fairly kind of clinical, lots of corridors, loads of signs, different words, long words, lots of very confusing things which make it feel like it's somebody else's place, not your place.
Quite hard to negotiate.
Hard to negotiate, and kind of, scary environment, and lots of people who are looking very serious, and so you've managed maybe to find your way using the signs to the place where you need to go. Then somebody says to you, okay, so what we now need you to do is we need you to get undressed. And we need you to get into bed. So you remove all of your clothes, you remove all of your personal effects, you've got to take your jewellery off, makeup off. You are, by that point, utterly stripped of anything which leaves you normally to feel in control, that you are who you are, all of your kind of normality, and you're taken back to your most vulnerable point. So you're not well, you're without clothes, you're without all of your personal effects, and you're now lying in a physical position which is lower than the person who's talking to you. So then this man or lady comes along who's got all the knowledge you need to help you put your clothes back on, put your hair back up, and get back out and get back to your life. That power difference is so great that realigning that back to some sense of partnership or collaboration, or actually let's be two adults and let's work this through together, so that I can feel that the decisions I'm making and the choices I'm making about what kind of treatment I want, when I want it, how I want you to work with me, so that when I leave,
decisions that are mutually informed.
Mutually informed, and that I am part of. So that when I go and you've done the bits that you need to do, I can then go away and look after myself. But I think what happens is the whole system is set up. However, I don't think it's ever meant to be like that, but actually that is the reality. And so you've got a power differential which is so huge that you are almost in a losing position before you've begun. So I believe extra work needs to be undertaken by the producers to actually address that power imbalance in order to facilitate somebody to be able to engage in an adult-to-adult relationship as opposed to a kind of paternalistic relationship.
Let's come on to directly the topic of patient involvement, because that sets the kind of the big issue, as it were. How are patients involved in the processes of the National Health Service in England and Wales? What are the ways in which they're involved?
Well, I guess there are two main ways, and within that there is some complexity, but actually if you take the name of my company, which is Patient and Public Involvement Solutions, actually those two words, patient and public, represent two very different things. On the one hand, it represents the patient, an individual who is looking to engage in their own care. So it's an individual who wants to be able to participate in decision making with the person that's looking after them, wants to participate in decision making with the manager who may be helping them to find the care, residential care thereafter. It is the individual wishing to share their personal experience that may have been good and may have been bad, but it's the person who wants to influence their own care and their own journey in that care process. So the patient as an individual, my care, as opposed to the other aspect, which is about the public, which tends to be more about our care services. What do we as
much more like
citizens-
accountability, isn't it? It's much more like the
It's a-
local councillor, in a sense.
I guess it's about the role that a person wants to play or not, because
Yeah.
many don't want to play a role in it. But the role a person wants to play as part of their collective, as part of their community, as a citizen, to take part in decision making, to take part in influencing. So it tends to be much more about our care services, the commissioning of services, how they may be designed, how they may be planned. Who are we as a part of a group or a collective of other people? So part of the kind of community development world, the communities field, or sometimes that kind of elected councillor angle. It may be, I've heard it referred to as kind of citizen governance. You know, I'm a citizen and I want to be part of the governance processes that look after the services that keep us all, you know, fit, well, educated, whatever those organisations and services might be. So they tend to have very different drivers.
Yeah.
But if you don't, they connect, because individual experiences are what inform collective views.
Yes.
So if you don't actually connect the two things together, people tend to, you're talking about the collective public bit, if people only engage because they want to be an active citizen, they tend to engage in an isolated way, and it's more about how can I find a bit of power and control to shape those services, as opposed to coming at it from a position which is, I'm interested to make sure that my care is as good as it can be, and I am one individual amongst a whole community of individuals, 500,000, a million, 6 million in London. And what is my responsibility as an individual as part of that to contribute and make sure that the decisions that get made by managers, by clinicians, are those which are in the best interests of the people locally.